Okay, thank you very much for inviting me. My name is Magnus Hald, and I'm a psychiatrist. I've lived in Tromsø most of my life, and I work as a psychiatrist now in the drug-free treatment unit at the University Hospital in Tromsø. And before that, I, for several years, was the director of the Division of Mental Health and Substance Abuse at the hospital. I just resigned from that position just a year ago on Sunday. Okay, I'm supposed to talk about this. It's a big theme, and it's difficult for me really to talk about both the organizational things and the clinical things at the same time, but I will try, and you will have to decide if I succeed or not. And I will talk about this, I think. First, a little about the context. Norwegian healthcare, Norwegian mental health, and then the drug-free possibility. And then I'll talk a little about Tom Anderson and the reflecting processes, working with reflecting processes. And I will talk a little about treatment network or treatment web, as I call it here. And I'll talk a little about the drug-free treatment program, and maybe I'll end up with directions for mental health, the way it looks, at least in Norway these days. I think I should say a little about the Norwegian context first. You know, Norway is a very long and thin country, scarcely populated, around 5.2 million people, 15% immigrants. And the very biggest immigrant group is from Poland. More than 100,000 Polish people live in Norway. So that's, and that's more than double of the size of any other immigrant group. So that's interesting. Norwegian healthcare is basically a public system, and I think that's very important for us. We work within the public system, and that's the opportunity that we really have. Also, psychiatry then is a part of this public system, where we have local town responsibility, which is organized with the general practitioners, home nurses, support personnel, day centers, things like that. And we have the specialized healthcare, which is a state responsibility, and it's organized in Norway in 4 regional health trusts. It's both local, community-based psychiatric centers and psychiatric hospitals that's part of this specialized mental health service system. And as I said, it's organized in 4 regional health trusts, and the northernmost health trust is called Helse Nord, it says there. That's the northernmost part of the country, and it's even more scarcely populated than the rest of Norway, and the distances are very vast. Within this region, there are 4, within this Northern Norwegian Health Trust, there are 4 different hospital groups. And the biggest hospital group is the University Hospital of North Norway, which has some regional responsibility, but also local responsibilities. And it's a psychiatric hospital for part of the catchment area. And it's even local hospitals and psychiatric centers for a smaller part of the area. So that is how the psychiatric system is organized. The University Hospital is the Division of Mental Health and Substance Abuse. It's rather big, with both the major hub in Tromsø and also the different small psychiatric center outside of the city. And there are some 1,000 employees in this service system, in this specialized healthcare service system for psychiatry in the region. There are 2 central important messages that I think I should talk a little about when it comes to the way healthcare is developed in Norway. One message from the central government is the golden rule. You might know the golden rule is the law of reciprocity in many religions. It's the principle of treating others that one would wish to be treated oneself. But when you talk about the golden rule in Norway, this is not what people think about. The golden rule in Norway today is that treatment programs in mental health and substance abuse shall have higher yearly growth than programs in somatic medicine. So this is a very ambitious statement from the government, but they're really working on trying to fulfill this obligation here. And it goes both on number of employees, waiting time before consultation or treatment, number of outpatient concentration and economic growth. And this has been the goal for at least the last 6 years in Norway. And it's not been achieved every year, but it's something that people are really working on trying to achieve. And it's because, as you know, there's a much more automatic growth in somatic medicine because of all the technology that's kind of driving itself, and the money has to go into that also. So this is ambitious, and Norway uses more of the healthcare resources on psychiatry than any other Western country. We use between 17 and 20% of the healthcare budget is for mental health and substance abuse. So I said there were two messages. There was the golden rule, and the other message is that we have now the patient's healthcare system. And that sounds, of course, very obvious that the healthcare system should be for the patients, but in many countries it seems that the healthcare system is basically for the healthcare professionals, and it's organized according to their ideas and thoughts and ambitions. But in Norway, the health minister or the health secretary, he said it this way: the basic question is, if the patient were given the right to decide, how would we organize and run the healthcare system? This is a radical question. The answer we get should be taken seriously, and it should be decisive for work with the patient healthcare system. So he says it's a radical question. And in mental health, there have been several answers to this, and one of the answer was the drug-free possibility, because the reason the drug-free possibility came about was that the server users organization, they united and had this initiative for drug-free treatment. 5 user organizations in Norway joined forces and demanded medication-free treatment possibilities for persons with serious mental problems. So this is the reason that we got the drug-free possibility. It's not because some psychiatrists or people working in the system wanted it. It's because the patients, the organizations of the patients wanted this. And it should basically, it was evident from the start that this should basically be a possibility for persons with serious mental problems to choose treatment that does not include neuroleptics. So that's the basic framework, I think, for drug-free treatment. And I have to go a little to the side here and say that in Norway, the way the government tells the different health trusts what to do is that they send out every year what we call a regulatory document. So they send the regulatory document to every health trust. For instance, from the Norwegian Ministry of Health Services, they will send a regulatory document to the North Norwegian Regional Health Trust. And the health trust will send a document to the university hospital, and the university hospital will send a document to the Division of Mental Health and Substance Abuse to tell us what to do. This is a part of, new public management of running a system. This is how it works. So we're supposed to do what we're told in this regulatory document. And for years, this has been a formulation, at least since 2011, this has been a formulation in the regulatory document from the government, that patients in need of psychiatric help shall, within prudent frames of treatment, have a choice of different treatment options, amongst these treatment options that do not include the use of medication. These options shall be developed in close collaboration with the user organizations. So this has been stated in the regulatory document for years. And what happened? Nothing. So in 2015, there was this special order by the health secretary that you have to. He demanded that the regional health trust, together with representatives from user organizations, ensure a proposal for a unified solution that is written down in a protocol and signed by both parties, that is the health trust and the affected user organizations. So the user organizations were also given a very central part in how to develop drug-free treatment programs by this demand from the government. And after this, we got money that made it possible for us to go on with this kind of development. And there was a document that stated that all patients in mental health treated with medication should have plans for tapering or termination of medication. I don't think that is in place yet, but that is a part of the effort in Norway, that all patients should have plans for this. And to obtain experience, we should establish at least one drug-free bed unit within each health trust. And we should include, as I said, user knowledge on an equal basis on the planning of this. It was then decided in the Northern Norwegian Health Trust that the drug-free program shall be established at the University Hospital of North Norway. The hospital shall give priority to the development of a bed unit with 6 beds. And the drug-free program shall have a regional responsibility. That means that the drug-free, these 6 beds should have a responsibility for this huge area, about 1/3 of the size of Poland, 480,000 people, but very long distances. So this is a special challenge for this very small bed unit to have this big area, this very big catchment area. And now for something completely different. This is Tom Anderson. He was mentioned earlier today. Some of you have met him and knew him. I worked together with him for 30 years, and he was very central in developing this meeting that we have here. It was Tom Anderson and Jaakko Saikula that together took the initiative to these network meetings more than 25 years ago. Tom Anderson, he started as a psychiatrist at the University Hospital, at the psychiatric hospital in Tromsø at that time in 1965, and it was of course very scarcely populated also at that time, but the central institution was very big, very many beds and very few professionals. And he noticed that when he traveled around in the country and he started to travel outside of the hospital to where people came from, and he took along the patients, and he noticed that when the patient came home, they behaved completely different from the way that they behaved in the hospital. So he started to wonder about this, and he became very occupied with a contextual perspective. He said that, well, people seem to change according to the context in which they live or which they are. So he became very occupied with a contextual perspective on psychiatry. And at that time, the most obvious contextual perspective was family therapy. So he started training in family therapy, different kinds of family therapy. And in the mid-80s, we were several people that joined him in training in Milan approach in family therapy. And I could say a lot about the Milan approach because that's been very important for the development of work with reflecting team and reflecting processes in Tromsø. But the training in this was what started the development, I would say. But I don't have the time really to go into the Milan approach, but I would recommend that you read more about that if you're interested, because the Milan approach is quite fascinating. And we read the original book, Paradox and Counter-Paradox, by Mara Salvini Palazzoli and her colleagues. And this working in this way, or trying to work with the Milan approach. We went to Italy and had training, and we really tried this. It developed some kind of frustration that led into working with reflecting team. And what we basically did when we started to work with what we called reflecting team at that time was that we opened up the professional conversation for the patients to listen to. And that had a profound effect on the conversation amongst the professionals. First that, and also it seemed to have an effect on the work that we were doing with clients or patients. So Tom wrote an article about this in 87, that was published in 87. And after that, we traveled the world for a while talking about reflecting team. And at that time, we also learned that there were some people in Western Lapland that did something similar, and we invited them to Tromsø, and there came a car with 4 Finnish people. They didn't speak any other language than Finnish, but it was, after a while, they learned more languages. I mean, Jaakko, he's developed a lot since that car trip to Tromsø back in 1986 or 87, when it was. So, this is a little about the development of the reflecting team. And we started to wonder, yeah, what's happening when we have the reflecting team? And we then found out that what's happened is that we have these reflective processes, which is something you have in all kinds of conversation. And what is that? We thought it was basically that you have the possibility to change between listening, to being in a listening and a talking position. And working with reflecting team or reflecting processes mean that you really put an emphasis on the possibility of changing from a listening to a talking position. You emphasize that thing in itself, and that seems to be one of the important things with changing, with working with reflecting processes and working with reflecting team, and this can be done in very many different ways. So when we talked about this back then in the 80s and 90s, we would generally talk about this as some ideas that you might find useful or you might not find them useful, but you could try out something of this, and we would not consider this at that time as any kind of method, but some ideas that you could try to utilize if you find them fruitful in one way. And this also developed more into what you might call a relational perspective or a network or web-oriented perspective. So when we, this was some of us that were trying to develop a drug-free treatment unit, we had experiences like this. And when organizing a treatment system, we very often get confronted with, a treatment chain. And the treatment chain it's a difficult perspective, or I think a difficult metaphor for developing healthcare, because in a treatment chain, the patient is supposed to be at the lowest effective level at any time, and he's only supposed, or she is only supposed to be there. You're only supposed to be one place, and you're supposed to be at the right place. And how is that possible? It's very difficult in mental health to define what kind of condition you should be in to be in a specific place. Diagnosis does not really give you any clue. If you need to be hospitalized, or if you can stay with a family, or if you can work or not, it's very difficult to say that the diagnosis will help you. So it's difficult to find the kind of defined conditions that will tell you in which place you should be. And it also then undermines responsibility, because it seems that you very often will be at the wrong place. So specialized healthcare will say, well, this patient shouldn't be here. He should be living in his home. And the town would say, well, he should be in specialized healthcare. So it undermines kind of responsibility. It also implies the idea that knowledge is hierarchical, that you know more. In the University of Uvascular, you know much more than you do in Chiropodas, and in Chiropodas you know more than you do in the primary healthcare and so forth. But I think the idea of hierarchical knowledge is not a very good idea. So it's, in my opinion, it's better to look at knowledge as more or less useful in different situations. It's not better or less good knowledge. It's different knowledge that can be used in different situations. And also, this kind of chain thinking undermines development of knowledge, which generally will happen if you meet with people with different knowledge, because here you really don't meet. You just send the person to a different place. And also it then undermines continuity. If you have an outpatient, if you live in an outpatient, have an outpatient treatment program and need to be hospitalized, you will have to change the people that you cooperate with as a patient. So it's not good continuity. So we tried, or I at least tried to replace, when organizing mental health service system, tried to replace the treatment chain notion with the treatment web perspective. This is all, of course, only metaphors for what we do or how we do things. But I think the treatment web it more underlines shared responsibility. It enhances cooperation in a different way than it's possible in a chain perspective. The knowledge seems to be more democratic in a web perspective. If you meet with different people, it's very easy to see that the useful knowledge is something that you agree on and that is developed in that situation. That the local knowledge is what is important when you meet with people in a concrete way. And it also emphasizes continuity when you work in the network, because you're all a part of the network. Wherever the patient or the family or those that you're working with are, you're still a part of the same network. So the drug-free treatment program was organized. The way I participated in that was trying to take these things into consideration. And the treatment program was organized in this building in the middle of the picture here. This is the old psychiatric hospital in Tromsø. And it's important for me just to say that we had to organize this program within the framework of ordinary psychiatry. This is not something very on the outside of psychiatry, which it seems to be. We have tried to look into what kind of other treatment or drug-free treatment programs are there in the world. And it seems that many of these other programs, they're kind of organized outside of psychiatry or outside of mental health as something very special. This is not very special. This is a part of mental health. And it's been important for us to try to keep it that way and to say that that is how it should be. And also the drug-free treatment regional protocol, that's the protocol that was made with the regional health trust and the user organizations, and that told us how to establish this in one way, contained also things that linked to a more web-oriented perspective. For instance, it should focus on cooperation with local treatment programs. It should also be network-oriented. It should engage family of patients. So there are many of these orders that we got from the regional protocol that kind of underlines the necessity of working network-oriented. So this was the staff at the beginning when we started to organize our work, and I show this just to show you that there are quite a few people working in a unit with 6 patients. So this tells you something about resources in mental health in Norway, in my opinion, compared to very many other places. On the other hand, this is, people working day and night, every day of the week, so it's to have different shifts, you need quite a lot of people. And this staff, or the leader group of this staff, had to cooperate closely with user organizations in developing the program. So the planning process in very close cooperation with user organizations. And then there's a question about what do we think about when we think about treatment in this respect. And I think we will have different opinions about that in this program. Is the treatment what goes on a daily basis in the unit, or is the treatment the unit's place in the treatment web as a whole? So this is it's a challenge for us to work on this and find out how to describe what is treatment in our perspective, in this perspective here. Because, in my opinion, when you stay in a hospital ward, something meaningful should go on when you're there. If nothing meaningful goes on, then why should you be there? So there's developed a program that you can see. I think it's very important to have a relational perspective, that the people working in the ward, that they are able to relate to the patients that are coming there, and to be good partners in ongoing conversations with those that are there. And then also we have more things that you might call therapeutic efforts, like environmental milieu therapy, individual therapy, recovery workshops that we will have almost every day, art therapy almost every day, physical training almost every day. All these things that we have been defined by the regional protocol that we should look upon and see if we should include or not. But I would say, to me, the most important part of the treatment is what kind of place or what kind of role this unit will play in the web of the treatment program for the individual persons. So very many patients that come to this unit we will generally start by receiving a written referral from service system and patients, and then we will meet with everyone involved, either live or on Skype. So that's how we generally will start the treatment. So we will start the treatment with this meeting. And I think that for me, it's important that we try to plan most of what should go on in this kind of meetings. And there's a question for us, how much planning should we do when the patient is in the ward with only the patient, and how much of the planning should we do in the web when the patient is together with his or her family, with the professional at the local psychiatric center, and other people that are involved. And I think, to me, it's important that we try to really utilize the web in planning. So in this meeting, we will use some of the principles that were developed when we worked with the reflecting team and reflecting processes. We will use some of the same things. So very often there will be 2, maybe 3 people from the unit that meets the other people involved in this first meeting, and we will generally say that we would like some of them to be in a reflecting position, and we would explain to the people that we meet what we would prefer, but we would also be open to do things differently. So we would, in my opinion, there are 3 questions that are important that we try to look upon in this situation. And that is, first of all, how should we best organize this meeting? And we have strong ideas about how this should be done, but we should at the same time be open to other possibilities. And then, what is the history of the idea of this meeting? It's important for us to find out who thinks this is a good idea, who thinks this is not a good idea. I think in our experience, someone should think it's a good idea to engage in a drug-free treatment program if it should be possible to develop it as a good idea. But there are very many different perspectives on this, and we will often meet different perspectives in this conversation. And the third question is, how should we use this meeting? I mean, what should we talk about in this first meeting? And I think these 3 questions, to me, are very central questions in any meeting. So I would emphasize that I think it's a good idea. We very often take it for self-evident how we should talk and what people want us to talk about and things like that. But I think it's very important to be very clear that there are, in fact, different possibilities and that they should be addressed in a way like this, or maybe in other ways. But I think it's important to try to address them anyway. And we will also use some of the principles or ideas that were developed when we worked with reflecting team in these conversations. And we're working in this ward now with the training, continuously training of the people working there in this kind of conversations. So we would generally then have these reminders for the interviewer that let those that want to talk as long as they want to, and those that don't want to talk, be still. Notice expressions and words that moves. Don't introduce new themes. Be different, but not too different. Avoid explanations. So these are some of the ideas that we would try to remind the interviewer about before going into a conversation like this. And we will also have some reminders for the reflections. Generally, that the starting point should be the observed conversation, that one should talk to one another and so that one allows the people that listen really to listen and not to be responsible for giving a response immediately. We should use questions more than answers. Repeat what you heard is very often a good idea when you're in a reflecting position. Avoid interpretations and avoid opinions. So this would be, and also avoid referring to other contexts. So these would be some of the ideas that we would put into the idea of giving reflections. And when we ask some of the patients and some of the people working there, what are the difference between this ward and other wards in the hospitals? These are some of the answers that I've seen. It's that we have more of a web perspective than other wards will have. We focus more on wellness and health than illness and pathology. Tapering plans for drugs in use will generally be in place for most patients. This is a part of what we try to talk with patients about, if they use drugs, if they're not tapered down on drugs or have never used drugs. There's a combination of treatment possibilities. We should, as Jaakko said, we should be open for everything. But at the same time, we're a part of a specialized healthcare system, so there's a question about how open should we be for things that have, in no context, proven to be of any... for instance, there's been a question, how many people should we educate in acupuncture? Because some of the users, they want acupuncture. Well, we don't know that acupuncture is very effective with psychotic problems, but how many people should we then educate? Or we're a part of a specialized healthcare system, which is supposed to rely on science. It's difficult, so we get questions like that. So I will just end by saying, in my opinion, I see two different directions for Norwegian mental health, and I think this is also something that's also the case in other contexts than the Norwegian context. There's one very strong medical drive in mental health, at least in Norway, where a more disease-oriented or pathology-oriented model with standardized evaluation, diagnosis, and symptoms are very central. Treatment algorithms are very central. Manualized treatment, medication is very important, and standardized documentation is very important. In Norway now, there's being introduced what we call treatment packages. It's, in my opinion, not a very good idea, and it's a part of this direction in mental health. And then there's the other direction, which is the patient's mental health care system, which is based more on narratives, patients or web descriptions, patients or web's choice, patients or web's abilities, tailored treatment plans, and more a cell-genetic model. So this is the other, I think, direction that I see in mental health in Norway now. And I would just then end by quoting Gianfranco Cecchin, who said that we must constantly, in mental health, fight against regimes of oppression. We must fight against the people that talk about obedience. We must fight against silence. We must fight against the idea that differences are dangerous. We must fight against authorities. We must fight against medication, institutions, expert knowledge, centralizing, and consensus. Thank you.